So, talk to us about a little off track here from orthobiology. Talks about acute inflammatory response. Our typical, I'm old. I've been doing this a while. Our treatment before was try to reduce the inflammation, try to get the swelling out. Talk to us about an appropriate management of acute inflammatory response based on an orthobiologics background.
So that's actually an interesting thing because previously what we would try to do with an acute inflammatory response is calm down the inflammation. I think there's a delicate balance between helping mitigate the pain with acute inflammation and trying to get that to heal. So typically back in the day, like when I was in my residency, you would immobilize, you'd ice, you would use nonsteroidal anti-inflammatories. You would do everything to try to calm that tendon down. Now, initially for pain, there's a degree of that. But the one thing I tell people to try to avoid is NSAIDs. I think NSAIDs in general stop acute inflammation, which is great for pain, but we need acute inflammation in order for tissue to heal. So there's a balance. Now, if you're a professional athlete or even a high school or college elite athlete and you injure yourself and you got to get to the next game, you treat that acute inflammation a little differently because you need to get it to heal. So now we've learned the importance of making sure there's plenty of blood flow to the area, deep tissue work, dry needling, all those kinds of things. And then when you're elite enough and you want to, in an acute injury where you have to get back fast, you can apply platelets to it, concentrated platelets, PRP, in order to give yourself a hyperhealing response.
Very good.
There's a delicate balance, though. You got to make sure you don't light because the platelets are taking and lighting it on fire even more. And if you light that fire too much, they're not going to like you very much.
Yeah, you're not going to have some pain.
Yeah.
And so I think that's the thing too is like with the athletic training background was get rid of the swelling, get rid of the inflammation as quick as possible. Now it's kind of that middle road you're talking about where I think it's like as long as the inflammation isn't damaging tissue further by extending it or inundating it with too much pressure, then there's a certain acute stage that's actually good for healing, allowing all that, those natural elements. And
you don't want to shut it down completely. Like we used to think, shut it down. And now we think that, okay, you want to temper it a little for the patient's comfort, but you want to allow the body to go through that acute inflammatory process in order to heal.